Good evening, everyone, and welcome to the Autism and Epilepsy webinar. This webinar is one of a series of epilepsy and autism webinars that the Epilepsy Foundation of New Jersey and Autism Family Services of New Jersey will be presenting within the upcoming months. Please look to your email to see a final list of all the webinars that will be upcoming. I just want to go over some logistics of tonight's webinar. Questions will be answered at the end of the webinar. In order to ask a question, go to the questions box on your panel and type in the question. All attendees will be in listen-only mode, so we will not be asking questions verbally. After the webinar, you will be receiving 2 emails. One email will have a link to the recording of this webinar and how to join the email list for both Epilepsy Foundation of New Jersey, Autism Family Services of New Jersey, and CNNH, the facility that Dr. Mark Mintz is a part of. The other email that you'll be receiving is a survey about tonight's webinar. We urge you to answer these questions so we can get some feedback about the webinars that we're putting on and any suggestions that you might have about upcoming webinars. I'd like to introduce tonight's presenter, Dr. Mark Mintz. Dr. Mark Mintz attended medical school at the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School. He performed his pediatric residency training at the Albert Einstein College of Medicine, Montefiore Medical Center, and completed a pediatric neurology fellowship at UMDNJ, New Jersey Medical School. He is triple board certified in child neurology, pediatrics, and neurodevelopmental disabilities. Dr. Mintz is on the faculty at UMDNJ New Jersey Medical School and has been on the faculties of the University of Pennsylvania School of Medicine and UMDNJ Robert Wood Johnson Medical School at Camden, and is presently a member of the medical staffs of Our Lady of Lourdes Medical Center in Camden, Weissman Children's Rehabilitation Hospital, and South Jersey Healthcare and Bancroft NeuroHealth. Dr. Mintz is widely published in the medical literature and has been an invited lecturer at a number of national and international conferences. Dr. Mintz functions as the principal investigator on a variety of clinical drug trials, has been the protocol neurologist for a number of national pediatric AIDS clinical trials, and has participated on an array of committees and task forces of the National Institutes of Health and the New Jersey Governor's Office. Additionally, Dr. Mintz has served in the National Health Service Corps of the United States Public Health Services and has volunteered for medical relief missions in Romania and Russia. I will now turn the presentation over to Dr. Mintz, and again I just want to repeat that if you have any questions, please type them into the questions panel and we'll answer those at the end.
Thank you. You've seen that little bar on the slides?
I'm sorry, Dr. Mintz. Yes, we see the first slide of the presentation and you're good to go.
You're not seeing that little bar. Okay, good.
Nope.
Okay, thank you very much. And it was just mentioned where I'm from, so I'm just trying to illustrate that in one slide, and that is the Center for Neurological and Neurodevelopmental Health, interdisciplinary organization based upon a specialty care medical home where we're treating various neurodevelopmental disabilities, neurobehavioral, neuropsychiatric disorders, brain injury, neurological disorders, including epilepsy, with an interdisciplinary team and a very comprehensive model. We have an associated clinical research center which provides access to treatments that might not be accessible normally, and a nonprofit organization, Neurabilities, which was also established recently in 2008, and providing community supports. We provide services in the office, school, home, and community. And you can see a picture of our facility there, which is now on the Gibbsboro-Voorhees border in southern New Jersey, with some new facilities planning to open this year in Philadelphia and North Jersey. So first we need to talk a little bit about epilepsy, and then autism, and then try to put the both of them together. As you can see from this slide, there's quite a number of individuals that are affected by epilepsy, and even more families and relatives and teachers and other people that are affected from people who have epilepsy. It's quite of a wide-ranging problem. It's particularly a growing problem more recently with some of our incursions and various wars, and some of our servicemen and women coming home with traumatic brain injuries, which often is a precursor to epilepsy. And you can see here that the burden to society is not just an emotional and humane toll, but there's also a pretty significant economic toll. As many of you know, epilepsy can be a very disabling condition. Quality of life issues include problems with maintaining employment, normal activities, particularly issues around driving, and other higher levels of health risks in individuals with epilepsy, such as cigarette smoking and physical inactivity, and also impacts from treatments that individuals take, particularly side effects of medications. Epilepsy often begins in childhood or in young infants as well. The first time a person has a seizure peaks at less than 20 years of age, and then there's a second peak in the geriatric population, usually as a result of some acquired event such as a stroke or the onset of dementia. In pediatrics is a little bit differentiated from the adult population in terms of the clinical and electroencephalographic or EEG features of seizures and epilepsy, the response to therapy, and the outcomes. And the impact in the pediatric population is just as significant as it is in the adult population. So it's a very, very important public health problem. So what is epilepsy? I mean, epilepsy on a simplistic level is just recurrent seizures. But these seizures need to be unprovoked and not a result of some identifiable insult. Everybody has the capacity, everybody's brain has the capacity to have a seizure, which is a manifestation of synchronized electrical discharges. As you are probably aware, is that your brain is a very electrically active organ. At any given time, we can measure electrical activity of the brain. That electrical activity often results from various chemical reactions. So the brain is very active, and so what differentiates a seizure is just the organization of these electrical discharges into a pattern that can result in some disruption of brain function, and can sometimes outwardly manifest in some sort of clinical manifestation, such as a convulsion in the extreme case. But sometimes seizures can be very subtle, just a staring episode, for example, or a brief unresponsive spell for a second or two. And I think in my framework of thinking, we'll probably start going towards what I'd like to term epilepsy spectrum disorders, just like we'll talk about in a moment autism spectrum disorders. But because I think with epilepsy too, there are individuals who more classically fit into epilepsy, having overt convulsions and seizures that can be observed. But I think there's another group, maybe even a larger group, who have electrical abnormalities and changes of the brain that cause neuropsychological changes, emotional changes, problems in academics, and may in some cases be a sort of a precursor to developing convulsive seizures. So I think we have to think about epilepsy as something more than just seizures, if you will, or observable seizures, that we need to really explore and see how the brain is responding to various forms of electrical activity, and trying to differentiate what would be normal versus abnormal. So seizures themselves are a symptom or a sign. Symptom is something you could complain about, and some people can complain about seizures. In some cases of seizures, there's no feeling or awareness of a seizure, but in some cases there are. I mean, people talk about auras, which is felt to be occurring right before a more full-blown seizure, but at the same time, an aura is actually a seizure itself. It's an abnormal electrical discharge, and depending upon where that occurs in the brain, that will lead to what type of aura you would have. So if there's something in the occipital lobe, which is in the back of the brain, which has to do with vision interpretation, if there is an abnormal electrical discharge back there, you might have some sort of visual change. If there's something in the temporal lobe, there might be other bizarre manifestations of an aura, such as a deja vu phenomena, for example, is one type of aura. There are other auras that might be abnormal smells or funny sensations in the arms or the legs or even on the face. So there are various, it really depends upon the localization of the electrical discharge. That'll be what type of seizure manifestation it is. EEG morphology, or the way the electrical discharges look on the EEG, will help to determine what type of seizure someone will have. And other issues about seizures are their duration, whether they're chronic, occurring for longer periods of time, whether there can be some associated underlying reason for the seizure, such as a pathology like a stroke or a tumor or brain injury or something along those lines, or whether the seizures might also be associated with some problem in outside of the head, if you will, such as maybe a low blood sugar, which could cause a seizure, or changes in your sodium levels. So many different reasons why people can manifest seizures. So not all seizures are necessarily epilepsy. Seizures are also characterized by being paroxysmal. In other words, they recur. They're often stereotyped. In other words, they have a certain feature or manifestation as described, though some people could have many different types of seizures in the way they look. But most people will have a somewhat repetitive seizure that can be almost predicted and what it would look like. And seizures can also are characterized by interruptions in your awareness, and thus they'll interfere with your behavior. And those episodes will be associated with electrical changes in the brain that can be measured by EEG. Seizures are also often characterized by involuntary changes in control of body movement or function or sensation, awareness, or behavior. And these could be the more classic convulsive type of events where people have involvement of their entire body, and the body might get very stiff, or it might start to have what's called clonic movement, which is something akin to a shaking movement. But they could also be non-convulsive. There are absence seizures where people just have manifestations of staring and lack of awareness, which may be as brief as a half a second or a second. And then there's this concept of subclinical seizures, where there are electrical changes of the brain that are consistent with what we call epileptiform or epileptic-like changes, but no actual observable seizure. But if you do other testing, such as neuropsychological testing, you might detect some problems with memory, learning, or other issues, or there might be some association with behavioral changes. So again, seizures are really developing into more of a spectrum-like disorder. When you talk about seizures, you could actually classify them into some very broad types. There are those that start in one area of the brain, or what we call focal seizures or partial onset seizures. They can be very simple. In other words, there's no major impairment of your consciousness or awareness. And these could be motor problems. In other words, maybe a shaking of one arm or a hand, or maybe just a finger. Sensory types of symptoms, autonomic symptoms, which would be change in blood pressure, heart rate, and even psychic symptoms. And that's a very important concept that many people get labeled with various types of psychiatric disorders, particularly psychosis and hallucinations and schizophrenia. And in those situations, one has to be very careful that you're not dealing with a more neurologically based problem such as a seizure. And in such situations, based upon various features of the psychic symptoms, might imply that there may be a neurological basis. And it shouldn't always just be labeled as a psychiatric problem like hallucinations and not entertain the possibility of a neurological issue, because obviously the treatments will be very different. There are complex partial seizures. Those are focal or partial onset seizures that spread a little bit more, involve more of the brain mass, and lead to impairment of consciousness. And these can be with or without automatisms, which are repetitive movements, such as maybe lip smacking or tongue thrusting, or eye fluttering, etc. And then anything that is in the brain as a seizure that's in one spot has the ability to spread, not only to involve a larger area, but actually could then cross over from one side of the brain to the other side through a structure called the corpus callosum, and then you have a generalized seizure. So a lot of people have what are called tonic-clonic or grand mal convulsive seizures. Many of those begin in one part of the brain, though some of them can be primarily generalized at onset. In other words, as soon as they begin, it involves both sides of the brain, but then there are those that start in one place and then progress to the other side. So these generalized type of seizures are usually, involve both sides of the brain. These are primarily generalized seizures, not secondarily generalized. They don't have any identifiable onset, and they have various forms. One is the absence, or what some people call petit mal seizures, where people just have episodes of staring and unresponsiveness, again lasting maybe a half a second, maybe 5 seconds, maybe 10 seconds or more. And then there are various types of generalized seizures that involve movements, myoclonic, clonic, tonic, tonic-clonic. These are either stiffening or repetitive movement of the extremities or the head. And then there's the atonic, or some people refer to them as drop seizures, where you lose sudden tone of your muscles and control of your muscles or your head, and you might just drop. And then there's a number that avoid formal classification. Now you could take seizures and different types of seizures and maybe some EEG changes and the age of the patient and then put them into syndromes. So these are sort of different patterns that seizures might follow, and they might fit into a specific syndrome. These syndromes might be symptomatic. In other words, they might be from an identifiable cause, such as injury to the brain, or maybe born with some sort of abnormality of the brain. Many of them are idiopathic. In other words, there's no identifiable cause, and they're presumed to be genetic, and there's been an explosion in the understanding of the genetics of epilepsy, and some epilepsies now do have genetic markers, and many more that probably still have to be discovered. There are the cryptogenic type of epilepsy syndromes where you can't really define a cause, but they don't appear to be necessarily genetic. And then there are those reactive seizures, if you will, that might be prone. You might have a predisposition or a propensity or a lowered seizure threshold, and under the right conditions that might tip you over the edge into a seizure event, such as, for example, in young children with febrile seizures, they probably have a predisposition or a lowered seizure threshold, most likely on a genetic basis, and then they have a fever for many different reasons, and that's enough to really push them into a full-blown seizure event. And then there are those that have transient events, such as, for example, alcohol withdrawals can cause a seizure. An impact to the head might cause a seizure, but not necessarily long-lasting epilepsy. So these epileptic syndromes have many names to them and many different types, and there's a long list that I'm showing you here. We'll talk about some of them as we go through, particularly when we get into autism. There are some like febrile seizure syndromes that are relatively benign, where the vast majority of children who have febrile seizures do not develop epilepsy as an adolescent or adult. But there are a small percent that do go on to have lifelong seizure problems. There are pseudo-seizures, and what pseudo-seizures, pseudo as you know means false seizures. Pseudo-seizures are not epileptic. These are individuals who are having events, but these events are not epileptic in origin. They may be from an emotional disturbance or what's called a conversion reaction. But they still are events, and they still are medical problems. And the last thing that somebody should say about somebody with pseudo-seizures is that they're faking it, or that it's not a medical issue. These are true medical problems. They have often neuropsychiatric associations and need to be explored for their causes, and also need to be treated, but they wouldn't necessarily be treated like an epileptic seizure. And then epilepsy and seizures can occur as part of other types of syndromes that are listed here: chromosomal genetic problems, metabolic disorders, vascular problems, brain tumors, etc. Some of these disorders are rather high risk for the development of seizures. Not everything that is recurrent and moves is a seizure. There are many, again, types of events that are not necessarily epileptic. I mentioned pseudo-seizures, but there's a lot of different movements, particularly in younger children, that may look like seizures, may be very convincing for seizures, but are not epileptic. And there are many seizures that have these type of movements as part of their epilepsy. So it can be very confusing at times, and create a very a dilemma from a diagnostic standpoint. But as you can see here, the various movements that are listed, one of the big dilemmas is people who sort of faint or lose consciousness. In some cases that may be associated with a seizure. In some cases it may be just a fainting tendency. In some cases there may be a cardiac issue that led to unresponsiveness that can then also induce a seizure. But the primary problem, again, might be cardiac, and that's always the issue with seizures and epilepsy, is to find out what the primary cause is, because obviously you want to treat the cause and not necessarily just try to cover up and treat the symptoms of seizures. And there are various perceptual disturbances related to migraine. People have dizziness and vertigo. Even abdominal pain, sometimes in rare cases, can be part of a seizure phenomena, but in many cases is not. Particularly children have many different behavioral changes and disorders that families fear are seizures or developing into epilepsy, but they usually have other explanations and are not considered epileptic, particularly head banging, people who wake up at night with night terrors, screaming and sleepwalking and sleep talking, various type of rage attacks. And again, in somebody who has known seizures or epilepsy, all these types of behaviors and other things I listed can occur as well. And in fact, people who have pseudo-seizures, probably about half of them have known and real epilepsy, but also have these additional pseudo-seizure attacks. There may be problems with respiration, particularly again in younger children and babies, apnea, which is a cessation of breathing, or breath-holding spells. And again, you can stress the body and stress the brain to such a point where, for example, in somebody who's a breath holder, they may reach a point where oxygen levels are too low and the brain actually then kicks into a seizure. So they might induce a seizure or provoke a seizure, but that's not necessarily epilepsy. Gastrointestinal disorders, particularly reflux in young babies, can cause something that looks very much like a seizure, but it's not epileptic. It's an event that looks like a seizure, but not epileptic. And I mentioned cardiac issues, particularly the prolonged QT syndrome, which often presents with generalized convulsions. But the primary problem is an arrhythmia or a rhythm problem of the heart. Endocrine disturbances like low blood sugar, changes in sodium, magnesium levels can induce seizure events. So that's a little bit of background on seizures and epilepsy. And now, what does that have to do with autism? Well, let's just talk a little bit about autism and try to figure that out. Autism is a clinically defined syndrome, a set of symptoms and signs of various behaviors and developmental issues. In this type of problem, as opposed to epilepsy, where it can be defined by seizures and supported by EEG findings, in autism, the diagnosis is not dependent upon the cause. And that created a lot of problems historically early on with autism. In the 50s and 60s, people were talking about autism as a result of what they called refrigerator mothers, or mothers that were not paying attention or not nurturing their children, and thus that it was felt to be more of and people also labeled it as a psychotic disorder like schizophrenia. But, we came to our senses more in the 70s and 80s, and research helped that along as well, to understand that autism is a neurobiological disorder, an impairment of early brain development. This can occur before birth. It may also occur after birth. It may be the result of many identifiable biological problems and syndromes, or may be acquired because of structural changes in the brain as well. One of the problems with autism, as many of you know, is that there's a lot of associations with children with autism. It is now somewhat epidemic. We'll talk about that in a moment. But to keep in mind that an association doesn't always represent a cause and effect relationship, and we'll talk about that. In many cases of autism, there is an identifiable underlying biological reason or cause, particularly a growing number of genetic markers. So like epilepsy, autism is biologically based. And like epilepsy, in many cases of autism, we can't necessarily identify a biological cause. It's still biologically based. We just haven't gotten to that point as yet. And if we looked at autism 10 years ago, this list of biological causes, which would be much smaller, particularly genetic causes. So as time goes on, as research progresses, we learn more and more about autism as well as epilepsy. Particularly in the last few weeks, you've heard about some recent studies that came out from the Center for Disease Control and concerning the prevalence and incidence of autism, and it seems to be growing by leaps and bounds. The most recent statistics that were reported widely in the press say that now 1 in 88 children across the nation have a form of an autism spectrum disorder. In New Jersey, that number was 1 in 49 children. We used to be #1, if you will, in terms of autism incidence and autism prevalence, I should say. But now Utah seems to have taken that distinction, and New Jersey is now #2. This translates into over 1 million individuals nationwide. Quite a prevalent problem right now. It seems to be a male predominance in autism, as you can see here, almost 4-to-1 to 8-to-1. There's a high incidence in siblings. Again, that would suggest a biological issue and cause. There seems to be autism at similar rates in almost any culture that you look at. And there is an interesting studies that have come out in the last year or so showing that there's a risk with advanced maternal or paternal age. Again, these are just epidemiological indicators that there's a biological cause for autism spectrum disorders. So is it epidemic? These numbers that are being put out by the CDC, which by the way was an analysis of 2008 data. So we don't even know in the last 4 years what the numbers really have come up to be, but looking from 2008 and looking at previous CDC analyses, there's more or less a doubling. In California, there was some surveys done that showed major increases in a 10-year span. In Korea, they did a study of autism spectrum disorders. 1 in 38 children seemed to have some form of an autism spectrum disorder, and these were done with prospective analyses. In other words, they were actually testing the children. In the United States, what people did was examine medical records to get these numbers. So we think that the Korean numbers actually might be even more accurate. And what's the reasons for this? Partially it's explainable due to better awareness and detection and recognition, pushing the age of diagnosis because we have better testing instruments and more awareness. In some cases, it might be, if you will, differential migration patterns. Like in New Jersey, people are often moving to New Jersey if they have an affected family member with autism because they might want to seek services available here that might not be available in some other states. The diagnostic criteria has been changing over time, and some of you have heard of the changes that might be coming in 2013 with what's called the DSM-5, but we'll talk about that in a moment. There seems to be milder cases that are coming into the data. It may be that the data is detecting more people because of people are now accessing services at a greater rate, so their medical records are more available. Maybe record keeping is better. And there may be other artifacts, but if you take even that all into consideration, it still appears that about 50% of the numbers cannot be, of the increases cannot be explained just by those issues. About 50% probably can be, but another 50% can't be. So there seems to be a true rise over time, and it's again reaching epidemic proportions. Autism is defined as a spectrum disorder. As you can see here, what's known as pervasive developmental disorder umbrella or autism spectrum disorder umbrella. And there's 5 different subtypes that have been defined by the DSM, or the Diagnostic and Statistical Manual version 4, which is a mental health manual. And as we know, autism is not a mental health disorder per se. It's definitely a neurobiological disorder. But nonetheless, that's how the diagnosis has come about. And the 5 subtypes that they define are autistic disorder, Asperger disorder, a very rare form called childhood disintegrative disorder, Rett disorder, which has now been defined biologically based upon its genetics, and a more broad term called PDD-NOS, or not otherwise specified. In the DSM-5, they're talking about collapsing all of this into one diagnosis called autism spectrum disorder. And there's been a lot of controversy about that, whether that might exclude individuals from services because, for example, people with diagnosis of Asperger disorder may not fit into the new diagnostic paradigm. So there's still a lot to work out until this gets into play, which will be 2013. But I would say, let's think about autism spectrum disorders as biological disorders and neurological disorders, and then we don't have to worry so much necessarily about the mental health type of classification. So these are disorders of the brain, and there's various ways to diagnose that from a neurological perspective, and then secondarily you can use things like the criteria that are used in the DSM. So the problem with that type of diagnostic criteria, again, very non-specific, very subjective, qualitative, not a lot of objectiveness to these type of diagnoses. Ignores really the biological basis because the diagnosis is not dependent upon the biological cause, so that we really need to understand the DSM diagnostic classification scheme, whether it be 4 or 5, and whether we call it PDD or autism spectrum disorders. We need to really understand the neurobiological different subgroups, or what we call phenotypic differentiation, because that's very important when we're trying to determine whether certain treatments work or do not work. If we don't understand the biological different subtypes, it's very analogous to, for example, cancer. If you come up with a treatment for cancer, what does that really mean? I mean, there are treatments for different types of cancers, and the treatments can be very different because the cancers can be very different. So the same thing with autism. You can't really say I have a treatment for autism. Well, the question is, are you treating what type of biological subtype of autism? And the same thing with allergies, for example. I could treat allergies and reduce symptoms of congestion and stuffiness. But if I understand what's causing the allergy and eliminate the cause, the allergies will improve at a much greater rate than just treating the symptoms. And that's a very similar analogy for autism. We could definitely treat many of the symptoms, but if we understand what's causing those symptoms, the treatments can be much more targeted and effective. So what causes autism? Again, there's a wide range of manifestations and severities of what would be called autism spectrum disorder. In fact, we're not dealing with autism, we're dealing with autisms, the plural form, because there's many, many different biological causes and reasons why somebody has autism and how they reach that point. You could divide it a little bit into sort of the regressive forms, the more severe forms, where people have gained certain developmental skills and lose them and sort of lose skills. On the other hand, there's people with maybe up to 10% or more of people with autism spectrum disorders who seem to recover over time. There may be some subtle issues, but they seem to really improve, and that may be in part a result from earlier interventions. In some issues, particularly in the high functioning end, or the very high people with very high intelligence who have other manifestations like Asperger's disorder or high functioning autism, the question is, where do we draw the line between normality and abnormality? There's a certain neurodiversity in our population that we have to take into account. And then, of course, one of the biggest issues right now and questions that is not fully answered are and that raises a lot of concerns amongst people. If we do have a rise in the incidence of autism, is there something in the environment that is leading to that? Could there be genetic predispositions and susceptibilities that are triggered by certain environmental problems or exposures? And again, I mentioned again that association is not always causation, because you could always find in a large epidemic situation a lot of associations with autism, and they may not necessarily be causing it, but they might be making it worse. So more research needs to understand the environmental triggers. But there are many known biological causes of autism. First, we have to make sure that there's not something that's mimicking autism, if you will. For example, hearing loss, especially early on in infancy, will lead to poor language development, and then you'll develop, and if you can't communicate well, especially through hearing loss and it's not recognized, then you'll develop a lot of behaviors that are autistic-like behaviors. Cognitive deficiency, intellectual disabilities can cause or lead to behaviors that look like autism or be misdiagnosed as autism. And particularly early on in the first 2 to 3 years of life, I mean, there are various forms of developmental problems that lead to language delays, and not all language issues are autism, but they could also, again, anytime you have poor communication or impairments of communication, you can develop behaviors, and some of those behaviors can be autistic type of behaviors as well. But again, autism, there are many biological issues. Probably the main reason for autism in many cases is if you will, a disorganization of the development of connectivity of the brain. If the brain communicates through various nodal points called synapses, and it is the development of synapses and connectivity of different brain cells over time that leads to brain development, learning, personality, memory. Everything that we have is based upon our early brain growth and how it all connects up and works together as a network. And there are various, in many cases, genetic reasons, or maybe prenatal toxic exposures or infections or inflammations that may lead to a disruption of this development of proper connections of the brain, and in many cases could lead to an autistic condition. I mentioned before that there are many genetic markers, if you will, for autism. 10 years ago, maybe 1 or 2% of individuals with autism would have a definite genetic marker that we could test for. That's grown now to 30% and continues to grow every day. And again, it's not quite clear how genes and environment, that interplay, how that plays out in autism as yet. There are rare disorders, but very dramatic disorders called neurometabolic and neurotransmitter disorders that can have manifestations not only of epilepsy, but also of autism. There are, again, problems in brain development early on. Again, fetal exposures to infections and various toxins, prematurity itself, and malformations of the brain. And you'll see a recurring theme here that these type of problems could also lead to epilepsy. There are some controversial issues about neurotoxins in the environment, like mercury. That's been pretty much, that's an unproven hypothesis, but there might be other neurotoxins in the environment. People worried about vaccines is another unproven hypothesis. And autoimmune disorders, a lot of children have gastrointestinal problems. There may be infectious or viral exposures that lead to autism. In many cases of autism spectrum disorders, just like epilepsy, the actual biological cause is not known, but that, or can't be identified, but that does not mean it's not a biological disorder. And the problem, again, with these associated conditions like epilepsy, gastrointestinal disorders, etc., is whether they are just coincident or might be a complication, or whether there is actually a cause and effect relationship. And there's a lot of active research to try to pin that down. And of course, we'll be talking specifically in this talk about epilepsy and how it interplays with autism. Now, epileptogenesis, or what leads to epilepsy, overlaps with the causes, biological causes, to what leads to autism spectrum disorders. Again, symptomatic causes of any kind of structural change to the brain, whether it be from a vascular insult like stroke or an infection. Something called mesial temporal sclerosis is a very common cause of epilepsy. It's a problem on the medial side of the temporal lobe, and it's usually from a remote early vascular insult to the temporal lobe, which may be from various causes, and it often occurs even before birth, or might even occur during a prolonged febrile seizure in an infant. Tumors of the brain can lead to epilepsy for sure. There are some genetic syndromes that are associated with autism and epilepsy that involve tumors of the brain as well. Cortical dysplasia is a problem, a part of the brain where the neurons or the brain cells don't connect up as well and form a little area of poor dysfunctional area that's not growing very well, but it also could lead to seizures. I mentioned there are about metabolic disorders. I mentioned that seizures themselves can cause epilepsy, if you will. Again, prolonged febrile seizures are sometimes associated with mesial temporal sclerosis, and that could lead to long-standing epilepsy. Many cases, again, there's just not a known cause or identifiable cause, but it may be in some cases genetically predisposed. What's called neuronal migration disorders. Genetic disorders I mentioned, like tuberous sclerosis, is the one that's associated with tumors. There's growing interest in channelopathies in epilepsy. These are little areas or gates, if you will, on brain cells that allow different items, chemical items, to come in or out, like calcium or sodium. And there may be abnormalities in these channels that lead to seizures. In fact, most medications for seizures, or what are called anti-epileptic drugs, work on these channels in various ways. And just like autism seems to be a problem with overall connectivity of the brain, this also can occur in epilepsy for various reasons, sometimes as a cause of epilepsy, sometimes as a result of epilepsy. So they have very common beginnings, and if you look at the actual data on epilepsy and autism, you'll see extremely high instances of seizures and epilepsy in individuals with autism. You can see here, probably over a lifetime, it can be as high as 40% or more, particularly if you include EEG abnormalities or brainwave abnormalities. So, and you see higher incidence of epilepsy and autism in those that have some other neurological syndromes, such as cerebral palsy. In general, neurodevelopmental disorders have a higher incidence of epilepsy. It can often be a common association. It makes some intuitive sense that there's a problem with brain development that also then leads to seizures and epilepsy. But again, in autism, the incidence is very high. The association is very high. Then again, it may be some common cause. In some cases, it might just be a chance and coincidental occurrence. Things like childhood absence epilepsy probably have no direct relationship to autism, but there's a percent of individuals that will develop absence. There's a percent of individuals that will develop autism, so there's a chance occurrence that's going to occur in some situations. And there are some very specific epilepsy syndromes like Landau-Kleffner syndrome that we'll talk about in a few moments. So if there's such a high association, one of the questions is, when should you suspect seizures or epilepsy in those individuals who have autism spectrum disorders? And the answer really is probably all of them, because the incidence is so high. I mean, if you're talking 30–40% over a lifetime, you have to have a very high index of suspicion for seizures and epilepsy in those with autism spectrum disorders. But particularly if there's an individual who has an autistic regression, if somebody has epilepsy prior to developing autism, if you will, or being recognized as having autism, a history of status epilepticus, which is a seizure that's very prolonged, usually defined as 30 minutes or more. Some people use 20 minutes as a cutoff, but a very prolonged seizure, because that puts at higher risk for changes to the brain that might be more long-lasting. And in particular, if somebody's been identified with a neurometabolic disorder or some other genetic problem that affects the brain, you should have a very high index of suspicion for epilepsy. If there's any symptoms in individuals with autism, that would suggest epilepsy. That raises your index of suspicion. Inattentiveness, loss of consciousness, repetitive movements. Sleep disruption, again, that's very common in individuals with autism, but again, that might also be a manifestation or a problem or association with epilepsy. A decline in cognitive functioning or neuropsychological functioning. Psychoses I mentioned earlier. And any other unexplained recurrent symptom. There are specific epileptic syndromes that are highly associated with autism, what they call, in autism, they're called epileptic encephalopathies. They could cause various forms of cognitive and psychiatric impairments. There are rather specific EEG abnormalities that could be seen, different seizure types. They may occur at different ages. And the causes might be a structural problem in the brain, a metabolic disorder, or some sort of genetic problem. If somebody has autistic regression, again, epilepsy has to be high on the list, at least as an association, possibly as a cause and effect relationship. There are other causes for autistic regression that need to be looked at. And of course, the EEG might help to differentiate these different problems. So there are autistic regression with what are called epileptiform EEGs, or EEGs that have seizure-like discharges. But also there can be autism regression without epilepsy. And it's interesting to see how regression is related to epilepsy because there are a number of exceptions. But again, your index of suspicion should be very, very high, and especially if there's a regression not only for epilepsy but all types of underlying biological processes like metabolic disorders. So epileptic autistic regression in some cases can be defined by certain seizure types and certain findings on the EEG. In some cases, the epilepsy is not well defined. You could have autistic regression with spikes, which are seizure-like discharges on the EEG, but no actual clinical type of seizures. Some considerations when you have an autistic regression is to look for, and seizures, is to look for lesions in the hypothalamus, which can cause something called gelastic epilepsy, which is a inappropriate laughter. Gelastic refers to laughter. Lennox-Gastaut syndrome, which we'll look at in a moment, which is a very severe epileptic syndrome of various seizure types, including drop attacks. And also consider, again, any type of genetic disorder, items such as Angelman syndrome and tuberous sclerosis, which have very high incidence of autism and epilepsy together. Infantile spasms, which is a disorder that occurs, as the name mentions, in infancy, is a very severe epileptic syndrome, and as a result of infantile spasms, many children go on to manifest symptoms and signs of autism. An interesting area is the acquired epileptic aphasias. These are individuals who have developed language to a certain level and then actually start to go backwards or lose that language skill. And then you do an EEG and you see different types of EEG abnormalities that are consistent with seizure phenomena. Some fall into the pattern of Landau-Kleffner syndrome and others in ESIS or CSWS. And we'll talk about, we'll go in more detail in a moment on that. And then, of course, status epilepticus, I mentioned, could lead to autistic regression, particularly if it's involved with hippocampal or mesial temporal sclerosis. So infantile spasms, I mentioned, is West syndrome. It's associated with an EEG that's termed hypsarrhythmia, a rather disorganized EEG pattern with various types of seizure-like discharges. It's associated also with developmental decline. The seizures themselves are these spasms, which is hard to describe on the webinar, but are where the legs and the arms come together, sort of a flexion of the body. And they can occur repetitively in clusters. And the causes include genetic disorders like tuberous sclerosis, metabolic changes, structural changes of the brain, but also sometimes we can't actually determine that, what the actual cause is. And there's various specific treatments for infantile spasms, some which can cause actual normalization, but others, even after the seizures are controlled, still go on to develop autism and developmental issues. I mentioned Lennox-Gastaut syndrome, many different seizure types, including which can include drop seizures. very often associated with cognitive impairment and intellectual disability. Autistic disorder often comes out of Lennox-Gastaut syndrome as well. And again, it can be acquired, again, associated with brain malformations, brain injury, and other problems as listed here. But about 30% you can't necessarily explain why it's occurring. I mentioned Landau-Kleffner syndrome. Again, a language regression associated with changes on the EEG. It can be very abrupt or a gradual loss of language, particularly problems with understanding language. And autism is a common manifestation. It tends to occur in the first decade of life. Occasionally there can be clinical seizures, but more often or not, at least when it begins, it's just a finding on the EEG. In some cases, the seizures can be medication responsive, in other cases not. But medications, though they may control the seizures, do not necessarily cause a reversal of the problem, which is the loss of language. And there are other treatments for this as well, which we'll talk about at the end. In most cases, there's really no identifiable cause. And there may be a number of variants of this. I mentioned CSWS and ESES, so those are abbreviations for the long names that are shown here on the slide. And the differentiation is really, how, if there's clinical seizures or not, or just EEG features. But when you look at these EEGs or brainwave tests, you see these spike or seizure discharges very frequently, and particularly when they go to sleep, when individuals go to sleep. The same for Landau-Kleffner syndrome, for that matter. And almost 85% of the time of sleep, you'll see, for these two disorders, seizure-like discharges. CSWS and ESES also are associated with neuropsychological and cognitive decline and deterioration. Language is a big problem. Again, a loss of language that has already been established, particularly expressive over receptive. There can be behavioral changes like dementia, psychosis, dysregulated or disinhibited behaviors, and autistic-like behaviors. The EEG findings can be transitory in many cases, so there is some sort of biological switch or trigger to these disorders, as they can last for months to years, and it's really not predictable what would happen with a specific individual. And again, in some cases, they could be symptomatic, a result of structural changes of the brain, but it's not clear if those structural changes of the brain are a result of the disorder or a cause of the disorder. This is Landau-Kleffner syndrome. This is an EEG, and we don't have enough time to really go into EEGs in general, but suffice to say that on the left column, a relatively quiet EEG without any seizure activity. The middle column, you can see a disturbance there in the middle of the page. Those are little spike discharges or seizure-like discharges. And then as this individual falls asleep, you can see on the right side there, really very active, almost this sort of ESIS pattern where you have continuous spike and slow wave discharges, and these are seizure-like discharges. There's also something called Rolandic epilepsy, or BECTS. These are partial seizures which have often various manifestations where people are quite aware of the event, but they lose control of their mouth and can't speak as well. But they can have actual seizures, particularly at night. They have a specific EEG pattern with something called Rolandic spikes, but they tend to be relatively normal in their cognitive and behavioral development, and this probably has some sort of genetic underpinning. Now, I mentioned this in the concept of epilepsy because Rolandic spikes are quite common in individuals with autism, and of course, individuals with autism also can have very normal intellectual function as well, but this leads into this concept of subclinical findings. I mean, the question always is, are we only going to treat seizures, or is there a larger spectrum where there's also electrical changes of the brain that may be causing problems on a more subclinical basis, such as causing problems maybe with memory or learning? And that's a very active area of research right now, and I think something that needs to be taken into consideration. We have done some research ourselves and published it, and others have published, and as well as a lot of clinical experience that in many cases that there is the case that EEGs or brainwave tests can uncover and find electrical discharges in individuals that are not actually having actual seizures. And there may be different clinical clues on who might be at higher risk or not. But nevertheless, particularly in those with autism, again, the index of suspicion is rather high. We talked about this a little bit before, that in Landau-Kleffner and CSWS and ESIS, there may or may not be actual clinical seizures. But again, there's should be a high index of suspicion in those with autism. So in individual autism, or of course without autism, how do you evaluate seizures? Again, you want to try to classify it and determine if it's provoked or unprovoked, and if there's an identifiable cause or mechanism. Do a good examination, get a EEG so that we understand what the electrical nature of the epilepsy or epilepsy syndrome is, so that you might be able to classify it into a syndrome. There may be other diagnostic studies, such as an imaging study like an MRI, to determine any structural changes, or an electrocardiogram to make sure there's not some rhythm problem, laboratory studies looking at metabolic changes, as well as genetic studies. And then the question is, after that's all determined, to decide on treatment. Does that individual's seizures need to be treated, or particularly if there's no actual clinical seizures, is any treatment warranted based upon abnormal EEGs and neuropsychological changes? Risks of epilepsy is the concept of sudden death, which we'll touch upon in a moment. The risk of prolonged seizures, which could cause metabolic changes and injury to the brain. And of course, just losing consciousness or motor control can lead to a fall and cause a direct injury. Treatment strategies include primarily drugs that are called anti-epileptic medications, or drugs that are targeted to seizures, but there are also many other forms of medications that can be used, and there's also non-pharmacological treatments that are also very important in treating epilepsy, because in treating epilepsy, the target should not just be on reducing seizures, which is a very noble approach, but there are many other problems that people with epilepsy have, including cognitive issues, learning problems, behavioral issues, neuropsychiatric problems, and these all need to be addressed. And it's also very important to take very common sense precautions in individuals with epilepsy and seizures, so that they shouldn't be in any situation where, if they were to have a seizure or lose control of their motor function, that they'd be in danger, such as in bodies of water, etc., without being monitored. So getting back to autism, and now autism and EEG, who should get an EEG? Again, I mentioned you have to have a high index of suspicion, but how can you accomplish it? I've seen over the years many individuals with autism get EEGs using standard EEG technologies, and often are restrained or sedated, and that really not only that are there humane issues, but also it diminishes the quality of the EEG. So there is a newer technology I'll mention briefly, is dense ray electroencephalography, or EEG. Traditional EEG has been around for quite a number of years, and for 60 years there was really no change in the technology until the last 10 years or so. And traditional EEGs are still the predominant form and require a direct electrical contact with the scalp, so there has to be some scraping of the scalp. They use a paste called collodion paste to affect that electrical connection. And even in that situation, you can only get on about 19 to 21 electrodes. And it takes about 20 minutes to do that. Now, that's a very difficult task in people who are behaviorally challenged. So often people resort to restraining, or they use sedation, and of course there's risk of sedation. And it creates a lot of anxiety, and it's a very overall poor patient experience. And somebody who has an autistic issue is going to be even that more uncooperative the next time around. It becomes a very traumatic experience. The dense ray has a net that has up to 128, even as high as 256 electrodes, and it can be placed on in just a couple minutes because it uses a sponge interface with a saltwater solution. You don't have to abrade the scalp, and you don't have to use any paste or gels. And then using this in conjunction with various behavioral techniques, the study can be accomplished in very behaviorally challenged individuals. So we have a lot of success. That's what the dense ray looks like. Again, there's a lot more information. It creates a lot better spatial resolution. People have heard of the MEG, or magnetoencephalography. That's the machinery there. You can see that's not a very practical method of obtaining an EEG, particularly in young children, or particularly those with behavioral issues, because you have to stay very still in that machine there, where I showed you with EEG you can be mobile and you can watch TV, and we sometimes have our music therapist or behavioral therapist come in to calm the individual. The risk of epilepsy, again, we mentioned loss of consciousness can cause physical harm. Drowning is a problem, aspiration, that is getting material into your lungs, motor vehicle accidents. The cardiac effects, both, again, some cardiac issues will cause epilepsy and sometimes vice versa if you have an underlying cardiac problem. And the problem of exacerbating underlying disease. And other risks include cognitive and learning impairments, recurrent effects of medication. So seizures themselves can cause problems, medication can cause problems, various behavioral disorders, neuropsychiatric disorders. And there's also this concept of forced normalization where actually a beneficial treatment can lead to adverse behaviors. In other words, individuals who have a lot of electrical activity in their brain can have the inability to actually manifest adverse behaviors, and as you control and suppress the electrical activity, they might become more functional, and in some cases that can lead to worsening behaviors. So actually that might be a treatment effect. The other big risk for epilepsy is, and not often talked about, is SUDEP, or sudden unexpected death in epilepsy patients. It's a real problem. Fortunately, it's a very rare problem, but it's usually unexpected, non-traumatic. This is not associated with those individuals that might have a drowning episode from loss of consciousness. And there's also other, problems such as accidents and higher incidence of suicide and treatment-related issues from medications and underlying disease that also might cause problems, and as mentioned, status epilepticus and cardiac events. SUDEP is still relatively poorly understood, but it seems to have a higher incidence in those who have uncontrolled seizures and who are taking multiple seizure medications. And again, multiple seizure medications might be an indicator that someone is having uncontrolled seizures. High alcohol consumption and other lifestyle issues seem to also create a higher risk for SUDEP or SUDEP. Why this occurs is not quite clear. There may be what's called a sympathetic surge, but in many cases it's probably different reasons for different individuals why this can occur. It's an active area of research. Again, the treatment right now is basically to educate people about the risk. Unfortunately, it's rarely discussed. And to try to maintain adequate seizure control and try to achieve monotherapy when possible, or if possible, not always possible, and to avoid lifestyle issues that create a higher risk for SUDEP. There's been some old studies that suggest maybe that there are some medications that can be useful, but it's not quite clear as yet. There's no specific medication that is recommended for SUDEP. When someone has a seizure, of course, you want to treat them with first aid, as mentioned here, and invite you to go to the Epilepsy Foundation of New Jersey website for more information on first aid and treatment of acute seizures. And there may be, in some cases, particularly in a medical setting or through an ambulance service, the use, or even at home now, the use of various medications to try to control a seizure, an acute seizure that's occurring. Now we have various benzodiazepines or Valium-like medications that can be used even rectally. There's now some new ones that are coming out that are going to be intranasal that might be able to suppress an active seizure. Long-term management of epilepsy includes various approaches. Those are pharmacological, either medications, in some cases hormonal therapies like ACTH or prednisone and steroids for infantile spasms. There's non-pharmacological approaches, vagal nerve stimulator, different diets, particularly the ketogenic or modified Atkins diet. And in some cases now there's epilepsy surgery can be a very important modality for individuals and presents the possibility of even curing epilepsy if you can remove the area that's causing your epilepsy, and if everything goes well, sometimes there'll no longer be any seizures. In some cases after epilepsy surgery things are better, but someone still might require medication. Complementary approaches, in some cases some seizures are responsive to, for example, vitamin B6, but these are relatively specific types of seizures, and overall, other than maintaining good health, good diet, good sleep patterns, and overall appropriate lifestyle, There's no specific alternative therapy that's being used for epilepsy. Whether or not we can prevent epilepsy from occurring, that's a very interesting question that has a lot of active research, and certain medications and other approaches might actually prevent epileptogenesis, or the onset of epilepsy, and that might have implications for autism. And this is particularly true in some of the research that's being done for Fragile X, which is a genetic syndrome that has high incidence of autism as well as epilepsy. And there's better understanding about what might cause some of the brain changes in Fragile X that causes autism and causes epilepsy. So there might be some overlap there in how we look at both disorders. So again, there's a very important association with epilepsy and autism. Seizure medicines have other uses as listed here. They not necessarily, they have other effects on the brain, I should say, that are listed here, and aren't always just used for epilepsy. And in people with autism, particularly some of the behavioral stabilizing properties of anti-epileptic drugs, this could be an important consideration. So when treating with epilepsy in the context of autism, you have to really look at this as a spectrum issue, just like autism is a spectrum issue, and look at this as from a multimodal standpoint. Try to avoid toxicities, particularly medication toxicities, and understand that in some cases treating the seizures might actually worsen the behavior as a therapeutic effect, but in some cases it might be a result of the medication. And then to wind up this webinar, I just want to mention briefly that, in parenting a child with epilepsy, there's a lot of obstacles and a lot of issues that one has to deal with. You're dealing with the unknown in terms of the future. Is epilepsy going to resolve or worsen? And what you tell your child about this condition, and usually it is a condition, just like people might have asthma and diabetes and other chronic conditions. They should understand that it's a condition that needs to be treated, but it's not necessarily there may be an underlying disease that's causing it, but the seizures themselves are not a disease, and they need to be dealt with and try to control them. But individuals obviously and their families go through emotions of fear, grief, anger, and then finally acceptance. And this is a very normal reaction. But positive approaches and positive thinking, and allowing individuals and children with epilepsy in particular, as well as adults, cope with it and participate fully in life is very important, and improving self-esteem. Dealing with any of the learning problems from either the epilepsy or the medications, behavioral difficulties, encouraging full sports participation. Of course, driving is a lecture unto itself, which we don't have time to talk about. But in many situations, individuals with epilepsy have the ability to drive, and others there may be some restrictions. So in conclusion, there are many treatments, the various types of medications for epilepsy. There's not enough time in this webinar to go into detail for each of the medications. But there are some newer generation compared to older generation that have some advantages in terms of better side effect profiles, very good efficacy or effectiveness, various types of dosing forms which might be important for individuals who have trouble taking medication in standard tablet form. And there's even some exciting, at least animal research, to suggest that some might actually protect against the development of epilepsy. I mentioned epilepsy surgery. In some cases, it might actually be curative. There are a lot of non-pharmacological options that not only can be effective, but are very, very important in treating the individual, not just as someone who has seizures that need to be suppressed, but treating the whole individual. Remembering that epilepsy is something of a spectrum disorder. There are those that manifest seizures and those that as yet may not have manifested seizures and have other issues and difficulties from the electrical changes of the brain. Some of the diagnostic approaches we mentioned, there are some new patient-friendly technologies. And overall, we're entering a new age of epilepsy, hopefully soon a new age of autism as well, and maybe both disorders might help to understand how each of them arise, where at least in epilepsy, there might be a cure from epilepsy surgery. There's better treatments for autism, and obviously everybody is looking for a cure for autism, or at least certain subtypes. Seizure freedom is much more attainable in today's society, and overall, in many cases of epilepsy, quality of life doesn't have to be compromised. And that'll be the conclusion of this talk and webinar, but I'd be happy to answer any questions.
Thank you, Dr. Mintz. We actually have a couple of questions, and I'll read through those now. The first question is, as a parent, am I able to observe seizure activity in my 20-year-old son with autism as he sleeps, or is it only seen through EEG?
Well, it's a very good question. In fact, that's an active area in industry where there's a number of companies that have been trying to develop devices to detect seizures overnight. I mean, that is a big dilemma with many of our families who have children with autism, without autism, and epilepsy. Many of parents, go through very difficult times where they're up at night and very concerned that they might miss a seizure. And the answer is really it depends on the situation and type of epilepsy or seizure that person might have. In many situations, it might only be detected by EEG. I mentioned some of those disorders like Landau-Kleffner or ESES. Those are often only going to be detected by an EEG. In some cases, there may be other things that happen during sleep that might look like a seizure and are not. And then in some cases, people actually do have convulsions overnight and have actual detectable seizures. There are ways to define that by doing overnight EEG studies where the clinical manifestation, what you're observing, then is correlated to what electrical changes there might be. And then that can then tell you that movement that you're observing is a seizure or not a seizure. But again, in many cases, there's not any detectable movement or anything that could necessarily suggest someone's having a seizure. So in those with autism, again, if there's a suspicion of seizures, and then again, in everybody with autism, there should be a suspicion at least, and there should be other evaluations to try to determine what the risk is for that individual and what type of study they could have. Usually you can start with routine EEGs during the daytime, and then in certain situations someone might warrant a more extensive study overnight. But one of the big dilemmas, again, with families is getting sleep themselves, and people use monitors and people have been looking at video devices. None of them have really been very good as yet. People are even now looking at implantable devices to detect seizures, things that are actually implanted inside the head, so that individuals with very frequent seizures might not only have seizure detection, but there might also, that can then be linked to some sort of treatment device that might release medication, for example, or cause an electrical discharge to try to suppress the seizure. So it's very difficult. But in general, you can't necessarily rely on your own observation, and so you need to talk with your physician about other strategies to try to make you more comfortable overnight with your child, so that you yourself don't lose sleep over something that might not necessarily warrant that.
Thank you. The next question is, I heard seizures with autism often are outgrown first. Is that true? And second, how do you determine if the person has outgrown seizures?
So partially that's a function. If we're talking about seizures that have no known cause, or the so-called idiopathic or cryptogenic cause, or idiopathic causes, there are a percentage of individuals that will outgrow. Usually a transition point where this often occurs is around puberty or into adolescence. Particular epilepsy syndromes, for example, like rolantic epilepsy, have very high incidence where people will outgrow them, probably because they're more genetically predisposed and have some sort of biological trigger during childhood. But other problems, if somebody has epilepsy, let's say the result of tuberous sclerosis or some other underlying genetic or structural change in the brain, the chance of outgrowing them are much less. So a lot depends on the cause of the seizure, and then it also depends on how well they've been controlled over time, how they respond to treatment, for example. But in some cases it can be somewhat optimistic, depending on the seizure type, that there may be a reduction of seizures over time and reach a point where someone no longer needs treatment for seizures and might not have any EEG abnormalities. Now, the EEG is a very good predictor of seizure recurrence. So EEGs that have active spike discharges, even though somebody is not having that, somebody who has epilepsy who has had seizures, even though their seizures may be well controlled, that's still a predictor of seizures if you were to stop the treatment. So in somebody in that situation who has a normal EEG, that might be a better prognostic sign that they may outgrow their seizures and may not require treatment long term.
Okay, thank you. Can the dense array EEG be used overnight? Do you know of any office locally that has the dense array EEG?
The dense array can be used overnight. There's also a very new form of it that's going to be ambulatory that could actually do some home-based studies. The longer-term EEGs with the dense array use a different type of net that has a different type of substance in it so that it's longer lasting. The problem with the saline soaked sponges is they dry out. They can be wetted again, and that's often what we do in the office. As, you know, they might dry out after an hour, and or a half hour. We wet them again, so we can continue the study for a few hours. So you could actually use the sponge net for a long time, but somebody would have to be there and constantly re-wetting them every hour or so. And again, that ambulatory model is going to use a different type of interface, but still there won't be any scraping of the scalp that's necessary. We perform the dense array EEG in this immediate area. I don't know of any clinical center that's using this technology. I know there's maybe one research center that's using it in Pennsylvania, but I don't know of any clinical access in this area right now. But there are other facilities throughout the country as well as internationally that have this technology.
Okay, thank you. That was actually our last question for tonight. I would like to thank Dr. Mintz for his presentation. It was very informative. And if anybody has any questions, you can email me and I will contact Dr. Mintz and get those answers for you. I just want to let everybody know, remind everybody that there'll be 2 emails that you'll be receiving tomorrow. One with a survey, if you can fill that out about tonight's presentation, that would be great. And next, the other email will be coming from myself, Andrea Rassiopi, and that email will include a link to the recording of this webinar and also how to join the mailing list for both CNNH, Epilepsy Foundation of New Jersey, and also Autism Family Services of New Jersey. And again, I just want to thank Dr. Mintz for taking the time to present tonight, and please look forward to the Autism and Epilepsy series that we have, webinar series in the upcoming months. Thank you and have a great night.